Hello, everyone. My name is Monique Gainey. I'm a clinical research coordinator at the Emergency Department at Rhode Island Hospital in Providence. Today, I'm going to go through our study entitled Clinical Predictors of Acute Diarrheal Disease, a Bacterial Etiology in Bangladesh. There have been significant advancements in the treatment of diarrheal diseases over the past 10 years, with diarrheal diseases being the 7th leading cause of death in 2007 to being the 10th leading cause of death in 2017. Nonetheless, diarrheal diseases contributed to over 1.5 million deaths in 2017 across all ages, with over 1 million deaths among those over 5 years old, and 60.2% of those deaths were among the elderly population. If we compare this across countries, we see that rotavirus, cholera, and Shigella are the three most common causes of diarrhea among the developing countries, whereas C. difficile, rotavirus, and Shigella are responsible for diarrhea in developed countries across all ages. While there are several published studies that highlight the common etiologies of diarrheal diseases, especially among children under 5 years of age, few have analyzed what specific clinical predictors to look out for when treating a diarrheal patient among adults and the elderly. Such information can lead us to provide more targeted treatment options, thereby lessening the severity of illness, which is especially important in developing countries where resources are limited. As such, the aim of this study is to investigate the clinical predictors for bacterial etiology in acute diarrheal disease among adults and children over 5 years of age. This study was a secondary analysis of data collected from a prospective cohort study of adults and children over 5 years old presenting with acute gastroenteritis at ICDDRB's Dhaka Hospital in Bangladesh from March to July 2019. Exclusion criteria included those presenting with less than 3 loose stools within 24 hours, diarrhea lasting greater than 7 days, other diagnosis besides gastroenteritis, and prior enrollment in the study. Written and/or verbal consent was obtained from the patient or legal guardian prior to enrollment in the study. Trained study staff recorded a wide range of clinical and historical data for each patient, such as mental status, blood pressure, or medications taken prior to admission. A stool sample was collected for each patient and sent for culture, as well as PCR testing for E. coli strains. Pearson's chi-square analysis and logistic regression were used to assess the association between clinical predictors and stool testing indicating bacterial etiology. The main outcome of the study included significant clinical predictors of bacterial diarrhea in positive stool culture or PCR. Of the 749 patients enrolled in the study, 36 were unable to provide a stool sample prior to discharge, and a total of 713 patients had positive stool culture and PCR results for inclusion for further analysis. 493, or just a little under 70% of patients, had stool testing indicating diarrhea of bacterial etiology. Of those positive results, 256, or about 35% of samples, had growth present on stool culture only, 118, or 16.5%, had a positive E. coli PCR only, and 119, or 16.7%, had both growth on stool culture and positive E. coli PCR. The median age of included patients was 30 years, with a range of 5 to 90 years, and 50.9% of included patients were male. As illustrated in the chart to the left, of patients with positive E. coli, enteroaggregative E. coli was most common, followed by enterotoxigenic, enteroinvasive, and enteropathogenic. No enterohemorrhagenic strains were found. Of patients with growth present on stool culture, Vibrio cholera was most common, followed by Aeromonas species, Campylobacter species, Shigella, Salmonella, and other. Clinical predictors significantly associated with bacterial etiology of diarrheal disease included weak radial pulse, delayed capillary refill time, stool color observed by study staff, more specifically rice water stool, and prior use of antibiotics to treat the current illness. The odds of having a bacterial etiology of diarrhea decreased with higher systolic or diastolic blood pressure and increased with higher heart rate. Mental status and number of diarrheal episodes showed association with bacterial etiology but were marginally statistically insignificant. Observed blood or mucus in stool, reported fever in the past 7 days, and abdominal pain did not show an association with bacterial etiology. Nearly 70% of patients presenting with acute diarrhea in our study had a bacterial etiology of disease. Several signs typically associated with bacterial diarrhea, such as bloody or mucoid stool and fever, were not predictive of a positive stool culture or PCR in this study. Although other clinical predictors, including heart rate, blood pressure, capillary refill time, and stool color, were significantly associated. Further research to develop predictive tools for clinicians to identify patients, especially among the elderly population, with bacterial etiologies of acute diarrheal disease should be conducted in order to allow for timely and appropriate use of antibiotics. Thank you for your interest in this study and for watching our presentation.